Hello, friends. Welcome to the session of Conceptual Spine Connect today, where we are going to talk about the spinal tumors. So, this is important in regards to mainly a theory. Sometimes in the practical, they tend to ask these questions as well. When there are stations and OSCEs over there, also, generally, they might put in some scan which is of a tumor, trying to ask you details about it. So, what are the learning objectives? To define primary tumors, to define secondary tumors, to understand the presentation and what are the different available diagnostic modalities, what are the principles of the management, and what are the prognostic indicators. Until and unless we don't understand the prognosis of a tumor, it is difficult to understand how exactly will we manage these patients. So the primary tumors of the spine are rare. They comprise of less than 10% of the overall tumors of the spine, and more than 90% are actually secondaries. The spinal metastasis is reported to be 20 to 70% of the cases, 30 to 50 times more frequent in incidence compared to that of the primary bone tumors of the spine. Cases with spinal tumors comprise 4.2% of all the reported bone tumor cases. They often go unrecognized and misdiagnosed till the late stages. So basically, most commonly what we incur are metastases or secondaries, which are coming from some solid organ most commonly. Rarely some blood-related dyskaryosis might also be there. However, if ever I'm saying this is rarely, so even more rare are the primary tumors of the spine. Having multiple myeloma or such cases might be more common as compared to having the primary tumors of the spine. And hence, the metastases generally are 20 to 70% of the cases, and less than 10% are the ones which are basically the primary tumors of the spine. Overall, when we talk about the spinal tumors, 4.2% of them comprise of overall the bone tumor cases that are reported in the literature. The other challenge with these tumors is that these are often unrecognized and misdiagnosed. So the patient will keep complaining of back pain, and since the patient is not having any other symptom, generally they may, be unrecognized. A lot of times, these patients might also have a past history of a tumor, and 10 or 15 years down the line, they may have a lesion in the spine. They are still more common, I would say, as compared to the patients who would come to us directly with a primary tumor. And some of these primary tumors, when they just, a lot of times what happens is when they have a back pain, low backache, upper backache, they would go to an orthopedician. That person might just get an X-ray done. If ever it is a too initial of the stage, it might be also missed. And they might be just labeled as a mechanical back pain patient without any incidence of tumor. And this would keep growing inside, and the patient is having the impression everything is fine, however, the pain is not going until it becomes too big in size or with widespread destruction. Sometimes it happens that the patient with metastasis would come to us, wherein concurrent other symptoms might also be there, which might give us some idea that these patients are having metastasis. They might be related to the pathologies in the kidney. They might be related to some general symptom like abdominal pain. They might be related to some symptoms related to the lungs, wherein the patient might have cough, hemoptysis, or bleeding from any of the natural orifices, which will basically tell us that possibly what we are dealing with is malignancy. Along with that, many a times, even these days, we have patients who come to us who would come and these patients would have already such widespread metastasis, and they would just come to us with pain in the back. And once we get these scans done, we would see that this tumor is already involving the liver, the kidney, and it is widespread overall. And one or two lesions are there in spine, which is actually the reported symptom because of which the patient started undergoing the investigation. Clinical findings: patient with a history of cancer, recurrent, recent, or in the past, with complaints of back or neck pain, which is progressive, unrelenting, not closely related to activity, and increasing during the night. So, in what cases you will actually be more vigilant? Basically, any patient who reports to you with a neck or a back pain, with a history of cancer, be it a cancer which is ongoing, recent, or way back in the past. Now, generally, these patients might come to you with a progressive pain, a pain that is not reducing, a pain that might not be related to the activity, and characteristically, the pain that would be increasing during the night. What happens is these tumors keep on growing. They may lead to pathological fractures and the invasion of the paravertebral soft tissues. So when the destruction is too much, these patients with trivial trauma might just get fractures. And because of this fracture, they start to get investigated, wherein we understand that this is basically a pathological fracture secondary to a malignancy. The patients might also come to you with pain, which would be as a radiculopathy, or in some cases, the patient might also report to you with myelopathy or spinal cord compression. Some lesions do not cause pain and they're completely painless. And that is how these lesions might be missed. Latent lesions, that is hemangiomas, fibrous dysplasias, exostosis, are asymptomatic and found incidentally on imaging. So, there are some lesions like this, wherein these particular tumors would be accidentally found, and you might not actually have any symptoms pertaining to that. Luckily, these are most commonly the ones which come in the benign category, for which we don't have to worry about a lot. Cases of incidental detection of chordoma are also reported. Chordoma is characterized by very slow growth and can grow to a very large size before being detected. So, there are patients who will have chordoma, and chordomas are known to, grow very, very slowly, and they can become very large also in size before they are actually detected. How they would be detected? In adolescent age group, they might be reported as a case of painful scoliosis. So osteoblastoma or osteoblastoma are notorious in causing painful scoliosis in adolescent age group. They would be coming to us with a fixed curve without a compensatory curve or rotation. What is the investigation that helps us to localize a lesion? So the technetium isotope scan generally helps us to localize a lesion. CT scan also displays a small island of pathological ossification, which is surrounded by a lytic halo, frequently by a rim of reactive bone formation. So how do you see these in the lesions on a CT? It would be a pathological ossification with a lytic halo, and there would be some reactive new bone formation as well. So this is a characteristic finding of a patient with a osteoid osteoma. Technetium isotope bone scan is also able to localize multiple lesions. PET or positron emission tomography can differentiate tumors from infectious diseases. So many a times, we actually are a bit confused if ever the picture is not classic. And we want to differentiate these lesions from infectious diseases, and that is where PET helps us a lot. Giant cell tumors and Ewing sarcoma are lytic conditions. Osteosarcomas, which are extensively aggressive pathological bone formation with ill-defined borders, might also be seen. Aneurysmal bony cyst, it is basically a multicameral balloon-like pattern with double density content. So, you have to differentiate between osteosarcomas and when aneurysmal bony cyst, wherein osteosarcomas are extensively pathological new bone formation with ill-defined borders. However, aneurysmal bony cysts generally tend to stay within the defined borders, and it has got a balloon-like pattern. And there's a double density, which is not so with osteosarcoma, which I'm going to discuss shortly. Chordomas are infiltrating erosions inside the vertebral body, which arise from the posterior vertebral wall. So this is one characteristic. And this was one of the things that was asked to you, which of these sentences is correct or incorrect, wherein it was said the chordomas arise from the anterior wall, which was incorrect, and it basically arises from the posterior wall. Peripheral chondrosarcomas, these are soft tissue masses which arise from posterior elements with rounded calcifications. Angiography basically can be done, and how does it help? Angiographies can tell us about the pathological vascularity, if ever there is any abnormal vascularity. and is helpful for selective arterial embolization. So in the cases wherein we need to embolize,